important aspect of what we do is provide comprehensive school-based behavioral health services. Comprehensive because we offer supports and guidance to both the students at Murdoch Middle High School and the teachers, and comprehensive because our school-based clinician offers a great deal of care coordination services for her young clients. We believe, and more importantly, the current literature on best practices in children's mental health care states that mental health counseling cannot be provided in a vacuum. Mental health counselors need to reach out to and coordinate their services with parents, teachers, primary care physicians, caseworkers, and so on, in order for young clients to actually benefit from therapy. An act relative to coordination of children's mental health care will require commercial insurers to do what we're doing in the Winchendon Project through funding support by the Health Foundation of Central Massachusetts and what MassHealth is already doing for its clients. It will require commercial insurers to pay for those critical care coordination services so that mental health clinicians can continue to reach out to and coordinate treatment with the adults in children's lives who have the power to make treatment successful. Research shows that children with serious emotional disturbances have the highest rates of school failure. 50% of those students will drop out of high school. Julie, however, because of the high level of coordination and collaboration that has gone into designing and implementing her treatment team, now has an academic plan that will likely work for her. She's found a group of caregivers, a school, and a community with the supports and resources necessary to support her ongoing struggle with mental illness. So in Julie's case, these things constitute a success. Julie is fortunate because her family is insured under MassHealth. This means that Julie's school-based behavioral health clinician was able to bill for and be reimbursed for all the time that she spent speaking to and coordinating care with Julie's family, her primary care physician, her psychiatrist, her family stabilization team, her intensive care manager, her teachers, her guidance counselors, and the Winchendon Police Department. Had Julie been commercially insured, like most children in Massachusetts, none of those critical care coordination services would have been reimbursable, which means that much of it wouldn't have happened. Productivity expectations in community mental health settings simply don't allow clinicians to spend time providing non-reimbursable
A program called Choices, which is designed to give a positive youth development aspect to at-risk youths. And the at-risk youths are identified through a network that we've developed in Webster through different social service agencies, through the schools, through the probation department of Dudley District Court, so we can better serve the youth. We look at it as a triangle where the child and the family is on the top of that triangle. They're at school part of the day, but they're out in the community for the rest of the day. And unless we're all on the same page and we're all working together and opening lines of communication so we can better serve.
I will tell you that my personal experience comes because I've had funding through the Department of Health to have a care coordinator in my office for the last 12 years. It's been supported by the Maternal and Child Health Block Grant System because our current system of reimbursement only supports, in general, direct service delivery and not for the collateral contacts needed for care coordination. So with the help of our care coordinator, we've been able to assist many families effectively linking between their homes, the mental health system, the schools, appropriate state agencies, and the medical home in a way that I think this bill will support. Let me share a story from my practice that will illustrate how collateral contacts allow us to coordinate care for children with mental illness in the context of a medical home. Oh, and like my colleagues, I've changed the names to protect confidentiality. Kenny was a 10-year-old boy who came in to see me with his father last summer. He'd been diagnosed with ADHD about 3 years ago. We used the AP protocols. We were treating him with a little bit of classroom modification on the 504 plan and a little bit of stimulant medication, and he was doing great. Until last spring, he started having angry outbursts at school that were very, very different from the sorts of behaviors he'd had earlier in life. It just seemed different to everyone. So we did what you're supposed to do. We referred him into the mental health system. He had a behavioral therapist. He had a child psychiatrist. And none of them talked to us. So we didn't know what was going on. He disappeared from our site until 6 months later he came back to see us because his psychiatrist was out of town and he'd been in the emergency room the weekend before. When I met him again, instead of being on a single medication, he was on 5 different psychotropic medications. I discovered that he had made it to the emergency room a total of 7 different times. I didn't know about any of them because emergency mental health is confidential. And he'd actually managed to have a 7-day inpatient stay at one of our inpatient psychiatric units, and I hadn't gotten a discharge summary from that either. All of this, as I wrote here, is with minimal discussion between the school, the psychiatrist, the therapist, the primary care doctor, and the inpatient treatment facility. So the father came in and said, "What do I do?" And we were able to straighten it out, mostly because I had a care coordinator. We got releases to talk to everyone. She spent hours on the phone talking to the school, the therapist, the psychiatrist, the hospitalization, DSS, DMH, the insurance company. I asked her to count up how much time she used. It probably came to about 10 hours of total time on the phone collecting all of this information and trying to figure out what would be a plan that would work, because his current plan was medications and periodic trips to the emergency room. That was not adequate. During this time, he got readmitted to the hospital. But this time when he went in, I was able to call the hospital and give them all of that background information. I'd collected it all. Previous time, none of that information had been collected, and it was all based on what the parents could remember in the middle of the night, which is just not a way to do business. With that, they were able to diagnose his psychosis, change all of his medicines, got him down to 3 medications, successfully control his symptoms, get him back into school, and get him into an appropriate treatment plan. Collateral contacts and care coordination were the key to unlocking this child's problem and ensuring that appropriate therapeutic interventions were instituted.